Hello everyone, this is Alraies from SIF 2021. With me is Dr. Robert Burke. He is the Director of Structural Heart Imaging at Honor Health. Dr. Burke, thanks for being with us.
Thank you, Shadi.
Today is the first day for SIF 2021. It's good to be back again live and meeting you again in person. I hear a lot of your talks over the course of a year, all virtual, but now it's good to be with you.
It's great to be in person once again, absolutely.
Exactly. Today, Dr. Isaac presented phenomenal cases of shock patient with acute MR or acute AS or AI, and the importance of having an intervention, structural imaging ready to help managing the patient and make the decision. Please give us your experience on that.
So we have a relatively unique situation. Dr. Isaac and I work together. We've been partners for the past decade, and we've sort of grown up in the structural world together, starting with TAVR. And while most of what we do, as you know, is entirely elective, it's scheduled, you have everything set, weeks in advance. There are cases that show up that are much more urgent. Somebody comes in with a ruptured papillary muscle or some other catastrophe. And realistically, the only way to address that again is really as the heart team. And my role in the heart team as really the primary imager, I take that very seriously. So when we do have people who come in off hours, weekends, vacation, whatever, realistically, it's not something that you can just say, oh, well, I'll be back in town or whatever. So you do have to really just accept that as part of the role.
Yes.
And so we've been able to build a program with the realization that for pretty much everything that we're going to do, it is a 24/7 obligation.
It is.
Again, these things don't happen often, but when they do, you don't have a second chance.
Absolutely, and that's what important. What you are seeing is important to make a decision that can change the patient life.
It's important because I think the decision is largely made before I even walk into the room that somebody is critically ill. And whether it's going to be me putting a probe in to help out with optimizing an impella placement or to go in and do an emergency MitraClip.
Yes.
You know what you're getting into to some degree, and it's just a matter of mobilizing the team and really having an imager who's willing to be part of the team.
Right. So I want you to give a word for all the fellows are interested in advanced imaging, especially for the structural space, that this is maybe becoming a kind of expectation to be part of that has this mentality as well.
It definitely is, and depending upon where things go specifically with mitral intervention and how much they're going to require a specific cardiologist to do the imaging moving down the road, it is an area that has a lot of potential for growth. And really, in order to optimize patient outcomes, and really that's the most important thing, you want people who have a lot of volume, who do have a lot of experience, and the only way to get experience is by showing up when it's inconvenient.
Exactly.
You really can't do this because, I've got this day and this day, my Wednesdays and my Fridays, I'm going to be able to show up. There has to be more flexibility in the schedule and in just your personal aptitude for going and doing these things.
Absolutely. So what is, you give us also a nice talk about imaging and technology for structural heart. What do you anticipate for the coming year in terms of devices that requires the eye of an imager to optimize?
Really, the biggest space moving forward is going to be tricuspid. Everybody is interested in tricuspid. It is a major challenge from an imaging standpoint. Now, whether that's going to be done with transesophageal echo, whether it's going to be done with ICE or volume ICE or some combination thereof, there's going to be a great deal of imaging that goes into that because once upon a time, everything in interventional cardiology was very simple. It was a one-man show. You go, put your foot on the fluoro, grab a cine here and there, and you're done. And really, that's all that was needed. Now, because we're dealing with soft tissue structures, you have to have ultrasound imaging. You have to be facile with that. And also, the interventional echo person needs to understand what the procedure is and how it works. How does the equipment work? When you're in a particular place, where is the device going to go next? How do you optimize? What might be causing things to be out of whack? You all have to speak the same language. It's not just show up, take a picture or two, and call it done. I jest that, I'm the staff photographer, but you need to understand what's going on behind the scenes so that you can anticipate where are we going to go and be able to track devices in real time in a 3D space.
And I think your job is becoming a little bit tougher because you have to see the device or to give it a view, but also you have to explain it to the implanter when and how and when to do it. So it's become a decision, maybe I would say 60-40 kind of thing, because it's becoming more challenging that you're the eye of the operator.
Yeah, I mean, you really can't get things done unless you see where you're going.
Exactly.
So, I get to be the navigator on this one or the co-pilot, but, it's an incredibly interesting space. It's only going to continue to grow, and I do believe that there are cardiologists who are non-invasive who will continue to want to do this stuff, and I think that it's a phenomenally interesting career path.
It is. Well, thank you, Dr. Burke, for your time, for your insight. Please watch these videos and others on SIF YouTube channel. This is Alraies from 2021.